Talk on the pelvic fractures. Basically, there isn't much that I'm going to talk to you about. Have you all had a good lunch?
Good sleep too.
Okay. Did you have your dessert? Did you? Did you like your dessert? I'm about to give you a little bit of my dessert. So basically, if you want to get yourself some strawberries, and you want to add the strawberries to milk, you can probably have strawberries in milk or a milkshake. And what I want to tell you about this topic I'm talking at the end of this day is that if you look at the what's going on? Never mind. Right, so basically if you look at the combined pelvic and acetabular fracture, and you think that the combined, again, the strawberry. We all like to look at the strawberry. So the combined pelvic and acetabular fracture, if you think that the combined pelvic and acetabular fracture is nothing but the summation of a pelvic injury plus an acetabular injury, you will probably end up with some reconstruction like that. But those of you who think that it is a different ball game, it's a third type of injury with a lot of milk shaking, this lecture is for you. So what are the learning outcomes of this talk? The first, I want to stress that when you combine a pelvic injury with an acetabular injury, it is much more than the summation of the two injuries. The second thing is that there are differences, there are similarities. Both of them can affect each other. And we are going to face several questions we need to solve. Which one should be reduced first? Which one should be fixed first? How the results can be affected. And if we have two injuries, we need to plan for the acetabular fracture, we need to plan for the pelvic injury, and you probably need to plan for the combined injury as well. Now these are basically the areas where you're going to face, this is the classic area where you have the injury, the pathological anatomy of a pelvic injury. And this is usually the zone where you have the acetabular fracture, the intra-articular component of the pelvic structure as a whole. There are areas of overlap. And that's how the confusion can come from the combination. Let us try to see why they are so different. Let's look retrograde. Let's start from the natural history of pelvic injuries. Now, the natural history of pelvic injuries are a little bit different from the ones on the acetabular side. And you can identify that by studying your scoring system, the Majid scoring system, for instance, as an example. For us as surgeons, objectively assessing the results and linking them to reduction is a bit difficult. This is why most of the scoring system pinpoint on what the patient tell you, how much they come back to the pre-injury functional level, how much pain they've got, their walking, their sexual function, their functional involvement in society, and so on. And that's why you can have actually an associated injury with a pelvis and an acetabular fracture. Both of them will not ideally reduce and fixed, but the main complaint of your patient is probably going to be around his hip. And this is why this patient needed to do a joint replacement to fix an inadequately reduced and fixed acetabular surgery. How many of us have needed to go back to an acetabular fracture that was not ideally fixed and reduced? I think the majority of us. How many of us needed to go back to a pelvic fracture that was not ideally fixed and reduced? Very, very few. So perhaps the pelvic fracture is a bit more tolerant to malreduction than the acetabular fracture. But is it the same with a combined injury? That's what we will see. And that will bring us to the indication of surgery. For an acetabular fracture, the indication of surgery we know is very minimal displacement. Any displacement within the dome, the acetabular fracture has to be surgically treated, reduced, anatomically reduced, and surgically rigidly fixed. What about all the indications of the surgery? You can even have to study that and measure it in detail. I think I'm going away. So even in millimeter displacement, we need to check that our acetabulum is anatomically reduced before we decide whether or not we need to operate on that. But what about pelvic fracture? The pelvic fracture involves another issue that we don't study very much significantly in acetabular injuries, the soft tissues. It's mostly about soft tissues. It's ligaments. And this is why the indication of surgery in the pelvic injury is not mainly about displacement. We care about the displacement as an indication of stability. So the main indication of an acetabular surgery is displacement, whilst the main indication for a pelvic surgery is stability. This doesn't mean that we should ignore the reduction, but I'm just pinpointing the core of the philosophy behind our surgical intervention with pelvic injuries. Okay. Let me give you another example. We can even be more confused when we reach the stage of diagnosis, when you want to assess the injury. Obviously, a sacroiliac dislocation is a sacroiliac dislocation. A symphyseal destruction is nothing more than a symphyseal destruction. But when you have something that looks like that, a lot of confusion can come in place. Let's try to have a look here. We have some kind of an injury around the sacroiliac joint. There's a destruction on this acetabulum, iliopectineal, ilioischial line. There's a crack here. There are many cracks in the pubic rami. Okay? I'm not going to leave you with this bad quality X-ray. This is not unfair to you. What about the 3D reconstruction? That's quite clear. The 3D reconstruction might explain why the confusion comes from. You might think this is basically a tetraramic fracture of a pelvis, and we have with this what we call a posterior column fracture. But from another concept you can say, hold on, this is not so. This is actually perhaps a T fracture with a pelvic fracture. And that can give you two different ways of approaching the management of this case. If it's a pelvic fracture, tetraramic with a posterior column, you might need to fix the pelvis separately, turn the patient on his front, and go from posterior to fix the posterior column. Whilst if it is actually an anterior with a posterior hemitransverse or a T fracture, depending on how you look at it, with a pelvic fracture, you might do the whole trick from the front in supine position. So a bit of confusion in assessment as well. Again, the time of intervention can be interplaying and influence each other. Most of the emergency management we've just seen this morning for acetabular surgery entails some kind of a closed intervention. You just need to pull a joint which is dislocated. Whilst most of the emergency pelvic fracture is related to hemodynamic instability, application of external fixator, and working in the middle of the night. How can this influence each injury? So, this will bring us to the $1 million question. When you have a combined pelvic injury with an acetabular fracture, which one should we reduce and fix first? So I'll pass the question to the audience. How many of you would rather fix the acetabulum first? Who would fix the acetabulum first? Our chairman will fix the acetabulum first. Who would fix the acetabulum first and reduce the acetabulum and fix it first?
Like the chairman.
So like the chairman. Who would fix it like the chairman? Right.
Fix both together.
Okay, who will fix the pelvis and acetabulum? The pelvis first before the acetabulum.
You mean the sacroiliac joint? I would raise my hand. Yeah.
Who would fix the pelvic injury first, then proceed with the acetabular injury? Okay. So let's try to see how each thought can be involved here. Sorry about that. If you think about fixing the acetabular fracture first, you would say, hold on, I've got a pelvic ring injury, which is more tolerant to malreduction. I've got a joint, which has to be reduced and fixed anatomically. And probably, I want to be sure that I'm going to fix the mobile joint anatomically first, and if I can obtain this, this is good. And actually, when the fragments are more mobile, they're much easier to get together, and then you can fix them together. And then again, those people would say that if you start by fixing the pelvis first and you don't do an anatomical reduction of the pelvis, this might hinder your reduction on the acetabular side. That's one way of thinking. The ones who would think about the pelvis first, and I would agree with that from my side, they would say, well, hold on, we need an injury fulcrum here. Mr. Ashari talked to us about the associated both column fracture. I'll just refer to this in a minute. And you would say, perhaps we need a pillar, something to fix the injury around and then build the whole rest around it. The other thing is that if you think that the mobile fragments are easier to reduce, you're losing all the effect of the ligamental taxus. Actually, it's the other way around. When you've got some part which is fixed and some parts mobile, it's much easier to reduce the mobile part on the fixed part. Now let's look at the associated both column fracture. This example is very much going all the way up. I'll show you on the CT scan right next to the sacroiliac joint. There's an injury which is going right next to here, and you can see that. Now, what we've been taught in managing these patients that represent what we call the floating acetabulum. Why is it floating? Because all the bone fragments are not connected with the axial skeleton. And that's pretty much like any combination of a pelvic injury with a dissociated sacroiliac joint with a T or anterior with posterior transverse. The acetabulum is floating. So perhaps the analogy stands true. And this is why some people will say you start from the back, the fragment right next to the sacroiliac joint. You proceed a little bit more anterior. You continue the anterior column, thanks to Mr. Acharya, he just told us that. And basically you continue with the rest. You can fix the rest of the anterior column to the posterior column. The CT scan here will show you how much high the associated both column fracture was existing. So this is what we do. We fix this part first, followed by that part. And then after you have a good fulcrum which you fixed, perhaps then you can finish the fixation of the anterior column with the posterior column as well. So that's the way you should think with an associated pelvic and acetabular fracture. And just to show you another example, which is important about how the malreduction of the pelvis can influence the acetabulum. This is an associated pelvic and acetabular fracture. Now I like to have a look at the inset here to see how much displacement on the acetabular side there is. So there is a destruction of the anterior wall, of the anterior line, of the anterior column line, destruction of the posterior column line. There is a double shadow of the floor. You can see that the teardrop has a double shadow. So perhaps there is a big fragment which is separated from the floor as well. And obviously, the sacroiliac joint, I don't need to stress on that. It's quite obvious to all learners. Let's have a little look further on. That's the CT scan that confirms the injury, and it also confirms the presence of the associated posterior wall with the transverse fracture of this injury. Right. So how do we proceed with that? The initial intervention was far from adequate. And you can see that whoever did that surgery left a sacroiliac dislocation which is not very nicely reduced, obviously ignoring the acetabular fracture. But what I want you to notice that the malreduced pelvic injury can have an influence not just on the posterior injury but also on the anterior injury as well. And that's again another close-up on the vertical malreduction. So what do? We have to go back in again. In this area, the malreduction that can be tolerated by a pelvic fracture cannot be tolerated by the combined injury. So you need to have an anatomical reduction of a pelvic injury when you have an associated acetabular injury to facilitate your reduction on the acetabular side as well. The pelvis has to be fixed by the hold rules, anterior and posterior, and the acetabulum has to be followed after the pelvic fixation. So that's a comparison of what was, what there is now. And that brings us again to the reconstruction of the acetabulum, that's the post-op CT. And that brings us to the summary. So I stress again that the combined pelvic and acetabular injury is not the summation of both. It's a whole different magnitude of an injury. And you have to plan it, and then plan it again for the third injury. Make sure that the pelvic malreduction is not tolerated by the acetabulum reduction, and results in these particular injuries can have many confounding variables. Thank you for waiting and listening to me.
Thanks for that. A very nice presentation that has woken everyone up. Now, this paper is open for discussion. Yes, Abdul.
Dr. Fajat, I want to ask you about whether we can differentiate between posterior-pelvic injury and anterior-pelvic injury, because when I think about combined pelvic and the cell fracture from my point of view, I will address the sacroiliac joint first, this for sure. Then I'll proceed for reduction of the acetabulum, and then if there is some malreduction, could be tolerated in the anterior ring. If I left those malreduction, it would be after I fix the acetabular component, not not just to fix the anterior ring and go to the acetabulum, then you will be confined, but the malreduction of the sacroiliac and the malreduction of the pubic ramus will be augmented in the medial segment. What do you think?
I think that this can be applied to specific type of fracture pattern on the acetabular side. If you have an associated acetabular injury, which is either a T or a transverse fracture, then you cannot do that. Because you know, as it has been described by the honorable speakers earlier on, that the way your transverse fracture rotates, it has to hinge on a fulcrum. And it has to hinge on the fulcrum, which is usually the symphysis pubis. But if you have a disrupted symphyseal injury, so you have disrupted symphysis, or even a fracture of the pubic ramus right next to the pubic bone, and you try to reduce the transverse fracture first, you will have a lot of difficult play here. Whereas if you reduce your symphysis anatomically, and you reduce it, obviously, most of the time you will start with the posterior injury first. And if you fix the anterior ring as well, then you have an acetabular injury that you can fix. The only difficulty about tackling, as you mentioned, any injury, whether posterior or anterior, in a pelvic setting, is that our mindset is programmed that a lot of the anterior injury do not really need to be anatomically reduced. They heal well, they don't leave such a residual problem with the patient. But when you approach them with a combined acetabular fracture, you have to think differently. Because you have to make sure that that displaced extra-articular component of your pelvic ring is a bit of a component of your acetabular fracture as well. And it can make the whole difference between a minimally displaced acetabular fracture and an anatomically displaced anatomically reduced acetabular fracture. Yes, sir.
Well, forget about the cases which gives you the chance to fix, to think about this first and this second and this arrangement. What is the proper maneuver to save the life of this patient when you receive a patient with combined fractured pelvis and acetabulum at the same time with a kind of hemodynamically unstable situation? What kind of resuscitation, what kind of first aid, what kind of stabilization you would like to do?
But this is different, completely a different topic.
This is not different. You receive the patient with
We're not
combined...
talking about first aid to
No,
the
not
patient.
first aid. You receive the patient with combined pelvis and acetabular injury, and you need to, the pelvis is open, and you need to save his life. How can we do this?
Basically, obviously, it's a very difficult scenario, and I hope you don't get pulled into most of the time. What you're referring to, sir, is that probably when you have an associated acetabular fracture, especially if it is an associated vocal fracture, where your iliac wing is commonly used when fractured, then you lose a tool to stabilize, which is the external fixator. So I think that's the interpretation of the question. Now, obviously, if you have a commonly used iliac crest, you can't apply an external fixator. This is just as simple as that. I can just give you an example of a simple case that was an open fracture with a wound going from one anterior superior spine to another contralateral injury, and the patient was shocked. And we basically went through the wound, and we did a very quick plate fixation to the sacroiliac joint, and the patient went through and he was fixed. But if you are in a scenario where you can't really fix and assemble all acetabular fracture, you can have one of two choices. One of them is simply packing. You can just open it up and pack. If you can't, if your resuscitation doesn't work. And the second thing is you can do a stage fixation, and we've done that in a couple of cases. What you basically do is that you try to fix an iliac wing. That doesn't take a long time. You can actually open up the iliac wing, you can fix them with plate screws, even if they're not anatomically reduced, they become rigid. Then you can basically pack the wound, put a couple of pins into the external fixator, and close it up. But that's an extremely rare scenario.
Any question? No, hold on, please. Right. Any comment you would like to add?
No, actually, having been working on this thesis for the audience under supervision of our Professor Dr. Hazem and also Professor Dr.